Good afternoon, everyone. What I'm going to present in next 15 minutes is something different. Even it was an opportunity. Bansi and Pratap, Dr. Pratap has always given me topics which are unusual, and this is one such unusual topic. So, what we are going to talk is the definition of obesity. Have we justified the recent definition of obesity? So, it was first recognized as a disease in 1948, and this is for the first time that after recognizing something as a disease, we are going retrospectively to tell that it is not a disease. Idea as a standalone disease is probably not working even after practically 75 years of its definition. Addressing the merit of this idea is a timely and consequential effect because defining obesity as a disease does not have any evidences at present. There are people who support that obesity is a disease, and what do they say? They say that objective evidence of an ill health requires the substantial barriers to access. So they say that if we don't declare it as a disease, there would be a catastrophe, and that's why it should be declared as a disease. By declaring it as a disease would provide stronger medical and cultural legitimacy to the condition and would prevent probably the stigma attached to it. There is a group of people which say that it's not a disease. Why do they say so? Because they say that by declaring it as a disease, by not saying that it is a disease, could reduce attention to the role of individual responsibility, thereby encouraging the unhealthy behaviors. So a group says that it would make the disease or the obesity accessible to the resources. The other said that it would create a wrong notion. So, a blanket attribution of disease status to obesity poses an objective risk of overdiagnosis. What is said is, if you declare it as a disease, you are exposing lots of people to unnecessary investigation, unnecessary treatment, and probably unnecessary surgeries, which the last speaker may not agree to. So, this dispute suggests that because the illness directly caused by obesity has also not been designed. So, again, not only obesity is not a disease, we are still not sure the disease is caused by obesity. So, number one, obesity is probably not a disease. Number two, diseases caused by obesity are not defined. Why? Because most of the time we say that they run glove in glove. But we do not have any evidences to say that these are the 6, 7 or 8 diseases caused by obesity. So inability to recognize obesity as a direct cause of ill health are not there, and therefore you always require some other disease to say that obesity is harmful. What does it mean? That such practices are effectively and unfairly deny access to the care. So obesity, what is obesity at present? It's a heterogeneous condition, and that many people with excess adiposity have no signs of ongoing illness. We see there are lots of people having obesity and still they are having good health. So we are not sure obesity is a disease. We are not sure obesity is associated with disease. We are not sure obesity leads to disease. And we are not sure even obesity is a risk factor. If at all it is a risk factor, the risk factor cannot be called a disease. So we agree, obesity is a harbinger of other disease. Yes. Obesity is a disease. We are not sure. Clinical manifestations of obesity, we are not sure. So, only thing that we know is excess adiposity. That is how the obesity has been currently defined. Excess adiposity can have quite different significance at individual level. What are the limitations of current framing of obesity? It is conceived and defined as a condition of excess adiposity that presents a risk to health. Nothing more than that. No evidence is that it causes the risk. It may cause risk to health. BMI, the harbinger of obesity. We all know the YY problems, or Dr. Yajnik found out that with the same BMI, a person may have adiposity or may not have adiposity. So BMI does not reflect body fat distribution. So the criteria that is there to diagnose obesity is also not reliable. So there's a question, are we actually diagnosing obesity before it causes problem? Are we diagnosing obesity before the disease occurs? Just like the monoclonal gammopathy of uncertain significance. Yes, it is a pathology, but it is not a disease. Same way, obesity may be a pathology, but it is neither a disease nor probably a precursor of a disease. So obesity, if it were only a condition of risk to the health, it would be difficult to tell that it is a disease. However, there are ample evidence that excess adiposity itself can directly lead to structural and functional changes. So, with this brief introduction to the topic, I think I made enough confusion in your mind as far as adiposity or obesity is concerned. And so, let's find out, how do you define a disease? For defining a disease, you require these important things: etiology, pathology, then compromised organ function and its clinical manifestation. Let us see whether obesity stands amongst this or not. Does it have etiology? Yes, definitely genetic, epigenetic. Does it have a pathophysiology? Yes, proven beyond doubt. Additional etiologies are also there. But when it comes to compromised organ function and clinical manifestation, we are not sure. And that is why obesity still does not hold the definition that we have created, that obesity is a disease. So, what are the recent consensus statements? One is, obesity is characterized by excessive adiposity with or without abnormal distribution or function of the adipose tissue. So, we can tell that obesity is excessive adiposity with some structural and or functional changes in the adipose tissue. Causes are multifactorial, acceptable, genetic, environmental, psychological, nutritional and metabolic factors are there. So now we reach a state where we change the word obesity to two different words, clinical obesity and preclinical obesity. So what is clinical obesity? Clinical obesity is risk of ill health associated with excess adiposity that has already materialized and can be objectively documented. What does it mean? That you require to document adiposity if at all you want to diagnose clinical obesity. Once again, I will make it very clear. You require to document adiposity if at all you want to diagnose, define clinical obesity. Not only that, you require to document adiposity, you require to document structural or functional changes in organs or tissues. And that's why there are so many changes. So it's now, obesity can cause systemic chronic illness independent of development of other medical conditions. It's not necessary that obesity should be associated with diabetes. Obesity should be followed by hypertension. Obesity should be followed by coronary artery disease. Preclinical obesity is characterized by a state of excess and or abnormal obesity, adiposity with preserved function. So adiposity, preserved function, preclinical obesity, adiposity, abnormal structure or function, it is clinical obesity. Why BMI based definitions do not work? BMI based definition said there is no obesity, no excess fat mass, that is athletes, while obesity, excess fat mass with no ongoing illness versus ongoing illness. So what are the implications? Now implication says that BMI only solely for diagnosis of obesity should be reserved only for epidemiological study. So first thing first, clinical confirmation of obesity. How can you confirm obesity? And then how can you diagnose clinical obesity? Two important slides. How can you confirm obesity? For confirming obesity, you require either direct fat measurement, that is DEXA or bioimpedance. If you cannot do it, then second thing, at least one anthropometric criteria, waist circumference, waist to hip ratio or waist to height ratio, in addition to BMI. So BMI alone for confirming obesity is no more valid. You require either two of these features, or you can directly document adiposity. Third one, or at least two anthropometric criteria if BMI is not there. This only confirms obesity, right? Does that mean that we have to say bye-bye to BMI? No, BMI is still a valuable screening tool. It just confirms the obesity when it is associated with one more criteria. Even the criteria suggested additionally, that is waist to hip ratio or waist to height ratio, they are also having lots of lack in specificity and sensitivity. Now coming to diagnosis of clinical obesity. See the difference between the two slides. One says confirmation of obesity. This parameter only confirms the obesity. And now this diagnosis clinical obesity. What it is? Number one, you have to confirm obesity with those three parameters. And then you have to document reduced organ or tissue function due to obesity, like signs or symptoms or diagnostic tests showing abnormalities in the function of one or tissue organ system, which I'll show in the next slide. Or you have to show significant age-adjusted limitation of day-to-day activities, which means the activities of daily living like bathing, dressing, toileting, etc. So if you can show by one of these parameters that there is confirmation of obesity, which could be by direct evidences like body fat measurement or one of these two, and if you can show organ or tissue damage along with those parameters, or you can show that the daily activities are hampered, only then you can say that the patient has clinical obesity. And these are different organ or tissue body dysfunction that are included in this number one, evidence of so now diagnosis of clinical obesity has become more confused. Once you diagnose clinical obesity, what would be the next step? The next step would be certain blood investigation like CBC, glycemia, lipid profile, renal and liver function test. You may require certain more investigation for workup if you want to rule out secondary investigation. So, simplifying everything, preclinical obesity versus clinical obesity. Preclinical obesity requires documentation of excess adiposity by one of the two parameters or both the parameters. It should show alteration in cells and tissue or alteration in organ structure. But if you want to say it is clinical obesity, you require alteration in organ function with end organ damage. Clinical manifestation, preclinical obesity practically nil, but clinical obesity has clinical, 3 slides only, clinical obesity has definite limitation of daily activities or signs and symptoms of organ dysfunction, and detection is required by all these things. So how can you go ahead? Elevated weight or BMI, it just gives you a clue. Clinical confirmation by 2 out of 3 parameters. So now you can say that the patient is obese. Then you go for assessment of clinical obesity with the help of organ dysfunction, and activities of daily living are affected. They are not affected, it is preclinical obesity. If they are affected, it is clinical obesity. I think I have clarified it very easily. Monitoring what lies in future is not a part of it. So, concluding the definition or concluding my talk, narratives and practices are made further cementing to the notion that obesity is not a disease. With no explicit characterization of illness, obesity is not a precursor of a disease. I am saying obesity, not clinical obesity. That leads to development of 2 more terminology: obesity, clinical obesity and preclinical obesity. Defining assessment of obesity and diagnostic criteria of clinical obesity is first step towards the new pathway in the field of medicine. The definition of clinical obesity fulfills an important conceptual gap in the notion of obesity. Such reframing provides a medically meaningful mechanism to inform diagnosis, clinical decision making. So, my topic was, have we justified the definition of obesity? The answer is, for the time being, it suffices to say that we have not been able to define obesity effectively, but by defining clinical obesity, we are probably on our way to do so. Thank you very much. Thank you, Vadodara. Thank you.